All right. Well, like Amy said, thanks everybody for coming. Hopefully, I know it'll be informational. Dr. Duellman I've gotten to sit through part of his presentation on that, and very, very well done. And I'm sure it'll answer a lot of your questions, as hopefully I will also. So I'm going to start out more on the rehab part of things. So just talking about hip pain in general, there are a lot of different reasons for hip pain, and Dr. Duellman may be going through some of those kind of a little bit more specific for what he looks at versus what some of the things we may see. One of the things that can cause hip pain is muscle strains. If you look at the muscles around the hip, this is just the front of the hip. You can see there's quite a few muscles around there, a lot of different ones you can strain depending on what your activities are. There are joint problems as well. This is the back side of the hip. So the first one is the front side showing the muscles there. Here are more muscles around the back side and showing the hip joint as well. A lot of people, perhaps some of you here, have been told you have arthritis in the hip. That's another thing, wearing down of the joint surfaces so that now you no longer have nice smooth surfaces like you'll see back on some of the total hip replacement joints, but you have bone on bone or some cartilage that's worn away. There's also referred pain. A lot of times you can have pain in and around the hip. People may feel like it's coming into the side of their hip, back side of the hip. That actually can be coming from your back. And so with therapy, if you come in for therapy, what we try to do is determine what and where your source of pain may be coming from. If surgery, even if it is in your future, you've been told you've had x-rays, you have arthritis, there are still things conservatively either prior to your surgery or occasionally after the surgery that we can do to help you along with that. Sometimes, again, if it's coming from somewhere other than your hip, when you come in to see us for therapy, we can kind of help determine that, and that may lead you back to getting back to what you want to do without necessarily having to go through surgery. Again, how therapy can help. What will happen if you come in for therapy? We do a thorough examination. We look at basically have you tell us your story on what's giving you the troubles. We look at the notes from your doctor to determine if they've done tests for you, what their finding is, and then we try to find out the reasons why you're having some of the movement problems and pain. And that's one of the things we really do in therapy is we try to figure out what is it that, as you come to see us, why are you having, what is either your pain or limitations that you're having at home? What are things we can do to address those and help you function better? So after your examination, a lot of times we'll maybe giving you some exercises for either for strengthening the muscles around the hip that you saw. Sometimes when those are weak, those will lead to the joint getting irritated and becoming inflamed. Stretching. A lot of times people, when your hips get sore, you may not move them like you normally do. And so when you go to use them, they're very stiff. That in and of itself can cause pain or lead to some of those changes and eventually arthritis or swelling at the joint. So we, again, try to address the movement problems. It may be appropriate to do some hands-on therapy. We do soft tissue mobilizations, deep tissue massage, joint mobilizations where we try to help that hip, if there's something where it should have more movement, we're trying to restore that natural movement that you should have in that hip to help it move better for when you're walking, make it easier for you to sit so that you're not continually irritating the muscles and the structures around the hip. We also offer recommendations, and this is one of the things, again, that even if you're thinking of having surgery, oftentimes you may be referred for therapy, and a lot of people are going, well, I'm planning on having surgery. But oftentimes we can make recommendations to make you more comfortable. It may be as simple as sleeping with a pillow between your knees when you're sleeping so that you're not placing as much stress on the joint. Sitting in an appropriate chair, oftentimes if you're having some troubles with your hip, there'll be certain postures and positions where that really aggravates the hip, and we can make recommendations. A lot of times it's one of those things where it's helpful to see you all individually because everybody's got different problems. So we get a lot of times, oh yeah, my dad's got this problem, and so, he did this exercise, but it didn't really work for me. Well, a lot of times you may have the you may have the symptoms that sound similar. You may even have the arthritis in the hip, but there may be something particular about either things you do during your day, whether it's standing and turning on your hip or how you sit, that just making little changes in that can make a big difference for, again, if you're planning on having surgery, but we can make those, weeks and sometimes months as it may be a little bit more comfortable for you prior to that. So, and activities, and that's where it really comes in handy when we see all of you and you come in and you tell us which problems or what things you're having troubles with, how you're limited, then we can design, specific programs or exercises to address those for you and try to come up with something that's, guaranteed, or not guaranteed, that's more specific to what you have going on and address that versus just a general. You can go on the internet and pull up exercises and, if you put in hip pain, but that may or may not work for you. Whereas again, when you come with a referral to see us, we can kind of listen to what you have to say and then also look through what the doctor has given us as well as our hands-on testing and try to find what works best for you. So if your hip looks like this, then you should see Dr. Duellman. There's here there should be more space there, and it's kind of pinching on things. Again, that may be something, and with therapy too, if you come, oftentimes we'll see people who are coming in for hip pain. Typically, any other therapist that you see, if you're not getting better within a reasonable amount of time, we're going to be sending you back or recommending that you would see Dr. Duellman anyway for a referral that way. So, again, there are many different types, degrees of arthritis, things that way. Even if you have arthritis, the research shows that regular, appropriate exercise, and that's what I was talking about before, really getting the right thing that's going to work for you, can help to decrease the pain as well as the stiffness. They've really done, again, with the research, it's showing that the more active you can stay. They used to say, you don't want to overdo things and really wear the joint down. Now they're finding that even with joints that have significant degeneration or wear on them, if you can do appropriate exercise, it may be swimming if you have really, not a lot of joint surface that's working there. It may be just regular activity as walking or biking, something that way, that if you do that on a regular basis, it doesn't reverse the arthritis, but a lot of times it makes it a lot more manageable to deal with. And so the bottom line is if you have hip pain, see your doctor. They're going to help with the diagnosis and discuss your options. They'll help you determine which course is right for you. And that's usually a discussion, and I think more and more people are having that with their doctors. It used to be, the doctor told me to do this. Definitely in this age, I think it's worthwhile, and I'm glad to see everybody here that you're getting that information where now you have that information and you can make more of an informed decision to say, I think I'd like to put this off, or I definitely think I need to go ahead with this for these reasons. Whatever your choice is, if you seek surgical route or therapy, the nice thing is you can get excellent care right here at Black River, either through rehab or the surgery. And I know growing up here, seeing the changes that have come for the hospital and being in other hospitals as well for care, this is a great place to work. And also, if I had to go for surgery, hopefully I don't, this would be one of the places where I would choose as well. So I will turn it over to Dr. Duellman.
Well, importantly, as Bill was talking, the most important thing that he actually had lots of great points. One of the things that comes up often is not my computer screen, but what to do with any joint, whether it be a surgical joint, a non-surgical joint, anything in that regard. And he's 100% on that joint movement is actually the best thing for it, and whether that be with therapy or activities of daily living and things like that, it's overall the best thing. So I'm going to talk and shut down and start over as we do this. So that's number one. Joint activity is by far the best thing, and so I would reiterate what he had said to that regard, that movement, basically what happens is when you move your joint, there's a fluid inside your joint that allows you to basically give nutrients to the cartilage. And so that's number one. So the other thing is the stronger you are before surgery or the stronger you are before anything, the better off you're going to be afterwards. So if you do therapy or whatnot ahead of time or do exercises ahead of time and those types of things, it's only going to help you coming out of surgery. It makes sense. The stronger you are before something, the stronger you are after. So about me, I grew up in Trumpelow County. I'm just southwest of here in town, Galesville. I don't know how many people know much of Galesville, but My dad taught shop there for 35 plus years, and my mom ran a daycare there. So I went to Wisconsin Rapids after training about 6 years ago, and have a clinic in Wisconsin Rapids. Black River and I got together sometime over the summer, and we decided to make this at least a off-site place for myself. I was going previously to a small town, to Adams Friendship, and we've since switched and come here for our outreach clinics. I have a master's degree in physical therapy, so my education started there. Did my medical training in Milwaukee, and then went to Springfield, Illinois for my orthopedic training. After that, I showed up in Wisconsin Rapids six years ago. The Biomed hip, or the anterior hip, became kind of I guess anytime you like something, you try to learn more about it. As you learn more about it, you get more involved. As you get more involved, it kind of grows to be its own thing. I first went and observed an anterior hip down in Texas. I want to say it was probably 2008. And after that, a couple weeks after that, I did my first anterior hip. And we'll talk about why that's a neat thing, or what the benefit is for you, for me, for the hospital, for anybody in general, if we can see the pictures. But the important thing is it really is. It's the same problem. It's hip arthritis or hip degeneration or hip wear, whatever you want to call it. But it's basically just a new approach. And we'll go through why that's neat and what it means to you. As far as the hospital here, I've been here since, I don't know, October or November, and I think we've done, as far as total knees, we've probably done, I don't know, 10, and maybe not 10, maybe 6 to 8, and total hips 3 to 4. It's nothing new to myself or to my staff. It's just a new approach to the hospital, or a new thing for the hospital here. So, what else do I do? Hips are basically kind of what tonight's about, but I do general orthopedics. I do everything except for the spine. If it has to do with your neck or back, no offense, I have no real expertise and or ability to care for those two problems. And those are typically taken care of by your primary care provider, and they will refer you on. If you come to me, it's kind of like asking the plumber to fix your car. I really don't know how to do it, and you don't want me to. So, but I take care of hands, elbows, shoulders, knees, ankles, feet. Would probably go to the podiatrist in town, Dr. Halstead. So he does a great job, and he's here on services. And so I would have him take care of those things. But my job is basically surgery. Most persons will see their regular doctor or their primary care provider prior to seeing me, and it's a more reasonable way to go. They'll usually send you out to therapy or what have you before getting sent to myself, or take care of it, try it with medical management and things of that sort. If that does fail, then yes, I'm around for the surgical side of things. All right, so it's the same problem, and the same problem is hip arthritis, or a problem with the hip. This is just a quick picture of a hip replacement with the pelvis is here, the femur or the thigh bone is here, and that's just a quick shot of what the femur looks like inside. Anyway, so born and raised in Galesville, bachelor's degree, those types of things. I did orthopedic training down in Illinois, and I joined Wisconsin River Orthopedics in Wisconsin Rapids in 2006. Obviously, I'm here in Black River, so I would love to see anybody and everybody here. I first began, once again, 4 to 5 years ago, saw my first surgery in Texas, and I performed the first Biomed anterior hip. ASI is just a hip from the front, more than 4 years ago, and I haven't gone to the backside since. There's a couple ways we can do the hip, either through the front or through the back, and quite frankly, you'll see why through the front probably will become the mainstay, or the new way to do a hip. Currently, I do help Biomed and teach other orthopedic surgeons on how to do the hip. I'll be going to Phoenix here shortly, and just got back from Miami a couple months ago to teach other surgeons as to how to do it. There are, I think, a couple other in Wisconsin now that are doing it. Tonight's plan, briefly, just a quick overview of arthritis, what it is. The surgical, non-surgical treatment Bill talked about a little bit. What is a traditional posterior hip replacement, and what is this anterior supine hip replacement? A brief video, if we can get it to work, and plenty of time for questions and There's all kinds of stuff in the back to look at as far as what total hips are there, what total knees are there, and just product literature and things like that. I had a joke that I was only going to allow people in who actually had an x-ray and could demonstrate they needed a hip replacement, but the hospital wouldn't let me do it. So, but anyway, the quick anatomy of the hip, just ball and socket. It's a very simple joint. On top of the ball, you have cartilage. That cartilage is what wears away. And if that cartilage wears away, that's what causes you to have arthritis. So the cartilage is basically the cushion. As you walk and step down onto the thigh bone, it pushes into the socket and you have a smooth surface, smooth on smooth. So all the exercises that Bill talked about, basically you moving this joint lubricates the cartilage, keeps the cartilage healthy. So that's why keeping mobile or keeping loose and active is a good thing. So what's arthritis? Arthritis is basically the degeneration of that cartilage. You start getting holes in it or pits in it. And as the baby boomer generation continues to age, we're going to see it more and more. The main types of arthritis are basically rheumatoid and osteoarthritis. This is the wear and tear arthritis, osteoarthritis. This is a little bit different, but the end result is the same. The joint degenerates and you get pain. The cartilage being gone doesn't cause pain. It's when you get these bone pits or this bone and it rubs on bone there. So bone on bone is what causes the pain. So what are your symptoms of arthritis? Well, this is just another schematic showing an inflamed joint, but the primary complaint that most people will say is it hurts in their groin. It hurts to lift the leg into the car or lift the leg into the bed, or you'll see somebody literally pick up their leg as they get it up into the chair. Yeah, you can kind of relate to that. And so that's the number one complaint. The joint, hip joint, does not hurt in the butt. It does not hurt up here. This is not your hip. If that's your problem or that's your pain, more likely than not, it's in the back. If it does hurt here and goes around the corner into the groin, yes, then you have a good argument that it probably is your hip. But kind of the rule of thumb is if it hurts, if you drew a line here, and if it hurts from here back, it's probably your back. If it hurts from here to the front, it's probably your hip joint. The other thing you'll see is you'll lose mobility. You'll lose the ability to turn your toe in. And so you kind of walk, do the Charlie Chaplin when you walk. Or if you watch somebody go in the snow. The other thing is when somebody walks, it's kind of fun. If you're bored at the mall, you'll see a hip patient and they'll walk and they'll have a waddle to one side. And they just tilt to one side typically, so they start to have a limp. Deformities, not so much. Knees, you usually get a lot of deformities. You get bow-legged and things like that, but hip joints, not so much. But you can. So how do you get a proper diagnosis? Usually about 95% comes from a medical history, just by asking the patients what their symptoms are, what their health history is, activity levels, what things they can and can't do, things like that. This part is typically done before I ever meet you, and we review that through your primary doctor's record. We examine the affected joint. We check for range of motion. Joint line tenderness is not really the hip, but we'll check everything. Joint deformities and x-rays. Mainly the person complains if you rotate their joint in or the hip in, they'll literally squeal or come off the table because it hurts so much. So this picture shows two bad hip joints. Excuse me. And what you see is you see a ball in a socket, but there's no space between the two. So they have bone rubbing on bone. The cushion is gone, and unfortunately it's gone on both sides for them. So x-ray is really the mainstay. An MRI does you zero good. It's a waste of about $4,000 to get an MRI of this hip. So if I tell you you don't need an MRI, I think it's probably just a waste of time and money. So here's just compare and contrast a healthy hip x-ray. You have a great ball and a nice socket, and you have a space here. On this side, there is no space. And essentially, you've got a square ball in a round hole. So you lose that motion and lose that mobility. As you lose the motion, your body creates bone spurs. So a lot of times you'll tell somebody you have bone spurs, but realizing that taking this bone spur off will do nothing. Because what's the problem? The problem, remember, is you don't have cartilage. And so you can go in there and whittle all the bone spurs off if you want, but the pain is still going to be there. Same is true with the knee, your heel, whatever. The bone spurs are just a sign that the arthritis is getting bad. So what can be done? First and foremost, activity modifications. This gentleman's carrying a walking stick or a cane. Typically, you'd carry the cane or the walking stick in the opposite side. So if it's your right hip that hurts, you're going to carry it in your left side. Heat and cold treatments might help the symptoms. Realize all of these treatments are literally to take care of the pain. None of them replace the cartilage. You can't do it. It's impossible. You have as much cartilage as you're ever going to have when you're about 4 to 5 years old, and you never get any more. So there's nothing that replaces the cartilage. So everything, whether it be medications, aspirin, prescription anti-inflammatory medications, steroid injections, the only goal of all of them are to treat the pain. And they're effective to a degree. I always use the analogy, pretty soon these things are trying to put out a house fire with a garden hose. They may help a little bit, but they're not going to take care of the primary problem. So, when do you consider a joint replacement? Basically, if all the conservative treatment fails that you've tried. And I will never tell anyone they need a joint replacement. And I just won't. You'll come to me and say, I'm sick of this. I can no longer do the things I want to do. I can't go for a walk with the family. I can't go for a walk with the dog. Whatever it is, you become ornery. And you're just, quite frankly, just sick of the pain and sick of kind of the song and dance of how to treat it. And when that becomes to that degree, it really diminished your quality of life. And that's the time you consider a joint replacement, not before. You don't do a joint replacement for an occasional pain, a little bit of ache now and again, because quite frankly, it's a big jump to cutting this ball off and putting in a new hip. That's a big deal. And it works, and it's very effective, but you want to make sure you've gone through all the conservative things first. So what are the benefits? 95 to 98% of the time, it essentially eliminates the pain. It's actually one of the most successful surgeries that we do in all of medicine, whether it be knee replacements, whether it be gallbladders or anything like that. It's the most financially sound as far as getting you back to being yourself and basically returning you to a healthy being. Obviously, if you can reduce the pain, you can enhance your mobility. If you don't walk because it hurts, those two go hand in hand, and with that comes the quality of life. What can you do is a common question afterwards, or what can you do after your hip replacement? Remember, walking, biking, swimming, tennis, golfing, racquetball, anything that's moving the joint are good. The only thing you have to avoid is jogging, running, things like that. But by the time you usually get to a joint replacement, you're probably not a jogger or a runner at this point anyway. So this is what a hip implant looks like. This is the standard kind of run-of-the-mill implant. What you do is you you core out a circle to put in this metal cup. In the thigh bone, you cut the ball off and you put a stem down, a metal stem, inside the thigh bone. Put a ball on top of that, and there's this piece of plastic sandwiched in between them. There's different varieties to that, and we'll show some of those things, but this is the main idea. Basically, you're recreating a socket and a ball, so you've got a smooth articulating with smooth instead of bone rubbing on bone. And once again, it's very, very successful. Just another picture. This one, you see the shell inside. This ball is actually ceramic, so you have an option of having a ceramic head on your thigh bone or on your femur. The stem, often question comes up, what's it made out of? It's made out of titanium. It flexes with the hip a little bit more than true stainless steel. Here's actually a picture of an implant. Nick has implants like this in the back. This is actually a ceramic ball, so it's no different than the ceramic in your living room. It's a little bit, or I mean in your kitchen. Hopefully you don't have too much ceramic in your living room. If it is, put the plates away. So that goes on top of there, and that's your new thigh bone to walk on. And it works very, very well. So metal on plastic, the first is kind of the tried and true. And that's what the majority of patients will get. If you're young, and depending on activity level, sometimes we'll put in ceramic. There's other options as well. This is a resurfacing. Very different than what you saw last on the previous x-rays. And this is basically a cap that goes on the neck of the femur. I will tell you, 5 years ago, this was done about 26 to 28% of all hip replacement patients. Now it's down, I think, to less than 4%. So if you hear about resurfacing, this is what it is. It's fallen out of favor for a couple different reasons, but the mainstay is I don't typically do this anymore. I was part of a trial in Springfield, Illinois that did these, and I did, 3 or 4 in Rapids. But It's falling out of favor for many reasons, but I just show it there for completeness sake. The important part is here you have a metal ball rubbing on a metal hip. So the idea was it would last a lot longer. And it does in most persons. So what's kind of the middle ground between this, which has probably fallen out of favor for many reasons, and the tried and true old plastic? Well, Biomed came up with something called vitamin E poly. That's just put plastic in the word of poly. This piece of plastic, or the cup, now they forced vitamin E inside of it or impregnated it with vitamin E so it doesn't wear away faster. One of the problems with this is there's a questionable increased cancer risk. So they said that's not a very good thing. So they went and made this with vitamin E, which then it doesn't degenerate as fast. So the question always comes up is how long can you expect the hip to last? It all depends on how many cycles, how much walking, but usually I tell people 20 years. So the goal for this is 20 years. If you start running on it a bunch, it's going to be a lot less. If you just get up and go play bridge or something like that, it's going to be a lot more. So everybody's different. This has a lot more options for myself in surgery versus the metal, and it's a great option. Actually, this is what everybody who has, not everybody, but everybody scheduled in Black River will get this versus the traditional. This is what we have in the building for us here. So, now why an anterior hip versus a posterior hip, or what's the difference? This is the traditional hip replacement incision. It's either on the side of the hip, curving to the buttock, or on the butt to a degree. Well, most of us have a lot of meat and a lot of fat right there. So you have to cut things to get in. So to get in to the back of this hip, you've got to cut muscles off. You've got to open them up and cut them. Well, if you cut them, that causes damage and it makes your recovery more. So that's the way we've been doing hips since Sir Charnley started them in the 1960s, was to go through, cut the muscles off the back, meaning your gluteal muscles, your butt muscles, and a bunch of smaller muscles. Well, what happened is a couple, 6 years ago, somebody came through and said, well, that doesn't make any sense. I can make an incision here in the front, literally in the front, and there's no muscles that need to be cut. If I hate to compare it to this, but if you ever skin a deer or clean a deer, you can put your finger between muscles and just kind of ride it back and forth, and the muscles fall to the side. And that's exactly what happens here. This approach to the hip has been around forever, ever since we started doing surgery. Matter of fact, if you're a child, this is how we get into your hip. So why, back 50 years ago, did we start back here? Was we didn't have the equipment engineered right. We didn't have the tools to do it. And so what happened is an engineer and a surgeon basically got together and said, this makes more sense. Let's get the instruments to work for the problem. So instead of being a kind of doing what the monkey always did, they kind of went through the process again to see if we could make the incision in the front. So the important part is you literally do not cut a muscle to get in this way, which is pretty amazing. Your incision is much smaller, so there's less tissue damage, less blood loss. I think this is a wash. I think you probably lose just as much blood, but you grow more, and so that's not a real big issue. So this is just another picture of a person laying on their back. This is a cartoon of the thigh bone and the hip. It's the wrong direction, the incision. You'll put it the other way, but this cartoonist at least had the idea correct. So I'm going to show a quick video, I promise, I think. So this is a cartoon schematic of an anterior hip. So the person's laying on their back, and you're making an incision right in the front. It doesn't quite open up like this, and that incision's much bigger than you would have, but this is just fat, and we just split the fat with our finger. And here you have a muscle and another muscle. And literally, you can just spread those muscles to the side. That's the ball. The person's head is going to be up here. This is a right hip. And literally, you cut the ball off the thigh bone, kind of odd to think of that, and you're going to take it out. So here the ball comes out of the socket, and now you have a socket here that you have to make round again. To make it round, we basically ream it a hole in there. Amazingly, the pain is very little, which is, when you watch this, it's crazy. This is a new socket that goes in, and we pound that in. Now, if you look at the picture up top, we turn your leg in a figure 4 position, and we can get in to the thigh bone. We have to make a space, so we clean out the marrow. And then we're going to do this twice. This is just too quick. And then the new stem goes in, and we're going to put a ball on top of that stem. So what you didn't see is you didn't see any muscles cut. And the amazing part is that this person's laying on their back, so it makes getting them in the operating room and doing the surgery that much easier. So I'm going to do that one more time. So that's the surgery in reverse. No. So once again, they're on their back, heads up there, right leg here. This is the front. So right on the groin, you're going to just, on the outside half of the groin, you'll make the incision. And you're looking for an interval or a plane between the muscles that's quite easy to find. And the idea is you cut out the bad bone, make the socket round again, and put the pieces in. It works very, very well. We typically just make one cut, but the idea is the same. And everybody's different as far as size. So we have different size reamers. We start at one size and go up to what's appropriate for that person. And you'll notice that that piece has a rough back. Your body grows into that. It thinks it's bone, so it grows into it and grows it rigid. Same thing with this stem that goes inside. Not that one, that's a trial. But the stem that goes inside has a rough surface on it, you'll see, and your body grows in to this rough surface thinking it's bone, and that's what holds it in place. Literally after a couple months, getting that thing out of there is a chore. Your body's grown into it. So that's the video. And then we close it up.
What's the recuperation time?
Depends, and that's a great question. Well, it all depends on where you're at as far as what you need to do. Meaning, if you're a worker at the local mill and you need to climb scaffolding or climb ladders and things like that, I think it's reasonable to say 8 weeks. If you want to go back to a desk job in a day or not a day, but in 5 days, 7 days, as long as you're not taking pain pills, go ahead. And so everybody's different as to what you do. I had a gentleman we did this to who worked as the Coast Guard, and within 2 weeks he was on the boats doing stuff. So everybody's different. So what's neat about this front approach? Well, this is a normal stem, the longer one. This is what we standardly use through a front approach. So once again, it's a smaller piece, but you'll see that the growth, the roughness, is essentially the same. So your body doesn't really care what happens down here with this stem. It's smooth. So it grows on to that piece. So you save bone. So I don't have to put something all the way down the canal. I can just put it in the top half. So you conserve bone, which is what you want to do at all costs. And it's an alternate to hip resurfacing. That picture we showed with the metal on metal, it's an alternate to that, so you don't use as much bone up. Once again, it's not new. And the primary rationale as to why I think it's better is it's a smaller incision. You're not cutting any muscles. That offers huge advantages, and I'm not talking just the short term as far as the first week, 2 weeks, or recovery. Has anybody ever had I guess I can't ask that, but if anybody's ever had a hip surgery from the back or on the side or to the buttock or whatever it is, they tell you 3 things you can never do the rest of your life. They tell you never to sit in a low chair or bend your hip more than 90 degrees. They tell you to never cross your legs, and they tell you never to rotate your hip, toes in, basically. And that's because they cut the muscles in the back. If you never cut the muscles, you never have to worry about those things. And so right now, the persons who do anterior hips, we give no restrictions for you for life as far as where you can put your leg in space. So that's a huge thing. So it's not just that you cause less damage, you made it easier for you for the rest of your life. So if you want to ride a horse or whatever it is you want to do, sit on the ground, crawl, kneel, those things, you can do that because you did not violate those muscles in the back. So here's the advantages, why you all should, or the patient or whoever thinks it's better. Less pain immediately, so you have a quicker recovery. The day of surgery, you get up and walk. So after we did that to you, you get up and walk, and you walk the halls, whatever. I did a hip replacement recently in a younger gentleman. He got up and walked out that same day, and literally walked out. Often, if you do a hip replacement from the back, you have to have a pillow between your knees for sitting or for whatever right away after surgery. You don't need that. The reason that's there, it's to prevent you from putting your hip in the wrong position and dislocating it. But once again, if you don't cut those things in the back, you don't have to worry about it. Decreased length of stay in the hospital. Most persons are here, and I say most, because are here for one night. So if we do surgery on a Wednesday, you go home on Thursday. You don't go to a rehab center, you don't go to a nursing home, you don't go to a place like that, because you get better at those places, but you don't get well. You get well at your own house, where you have your own bathroom and your own bed and your own food and those things. So if you ever come see me, one of the things I'll always say is, you're not going to a nursing home. And you won't. I can think of now 2 persons in the past 5 years or 4 years that went. One argued tooth and nail and she went anyway, and the other one had to go. But she probably, that's a different editorial. So, minimal need for post-op therapy. Most hips don't need therapy. I say most again. Obviously, there are people that fall through or that need it for whatever reason. But the majority of people don't need it. Whether you live alone or whether you live with somebody, you go home the next day. No restrictions on movement, we talked about. Less dislocation risk. The reason that if you do a posterior approach or approach from the back, they tell you you can't do those things is the ball may jump out of the socket. That's a huge problem. And so, knock on wood, I haven't seen a dislocation from the front, from a front approach. I'm sure it will happen someday. If you can imagine it will happen in surgery. But at the same time, I've never seen it, so we don't give any restrictions. And the other thing is better leg length control. One of the big problems, actually the biggest lawsuit that you ever have in orthopedic surgery with hip replacements is the leg lengths being wrong. And remember, the goal of surgery is pain relief. Secondary goal is pain relief. Third goal is a stable hip. Fourth goal is leg lengths in the same ballpark. With you lying on your back for surgery, we can measure your leg lengths while you're in the operating room. If we do that buttock approach or the back approach, you can't do it. So one of the things that Dawn does, Dawn's the nurse in the operating room with all of these, she will tell me if the legs are the same length or not. And if they're not, we take the hip out, do it again until we get the right length. That ball comes in different lengths, so we can lengthen you or shorten you depending until we get it right. So that's a pretty neat way to do it. And when you're on your back, I can tell you, 6 years ago and 5 years ago when I did the approach from the back, I'm a heck of a lot better surgeon from the front now getting the leg lengths exactly on than I was 5 years ago, 6 years ago, because you were guesstimating. So, for me, why is it better? Number one, I don't cut any muscles. If the patient's happy, then it makes me a little happy. Excellent visibility. It's amazing how well you can see from the front. Normal hip mechanics, because I'm not cutting muscles. Leg lengths we talked about. Dislocation risk. This is important. If I do that approach from the back, I don't get to use an x-ray machine because there's no way to put one in the room. It just doesn't work. This is actually a surgery that I was doing. You see exactly where the cup is going. This cup is just on an inserter, but I can see exactly where it's going. So there's no guessing as to if I'm in the right position or not. You have immediate feedback, and you don't hit it with a hammer until you get it right. And so that's it putting it in, and that's it after it's pounded in. You got one screw there just to hold that cup in until your body grows into it. So this is the other interesting thing is a lot of times that, in Wisconsin we worry about the size of the patient as far as being able to get in from the back. We all have a lot of muscle and meat back there. From the front, everybody's got about the same amount of meat. Never seen anybody that's really fat right in these two spots. It just doesn't happen. So it's easier to get in, quite frankly. It's much easier to get in. And lastly, happier patients. So what it means here in Black River, I think it's actually going to become the new standard of care nationwide. It just takes a long time to teach all the old dogs the new tricks. It's going to happen. Interesting things that we do, I think that is not interesting, but it's great. If you have hip surgery, you're healthy. We would never operate on you if you weren't healthy. You wear your own clothes to the hospital, meaning you bring your own clothes with you. After surgery, you wear your shorts or your sweatpants or pajamas or whatever you want. We don't dress you in a robe because that's going to make you feel like you're sick. We become dependent when we put on a robe. You're out of bed for breakfast, lunch, and dinner. You don't get to sit in your bed or lie in your bed. You had surgery to get moving, and we will get you moving. You're out of bed then for all the meals and throughout the majority of the day. You do therapy while you're here, but when you leave here, you don't do therapy. Therapy's all done. Your whole goal is mobility, and that's what we do. We get you moving. Why? Once again, no hip precautions. If you don't have much pain, you're not going to use much narcotics. If you're not using much pain pills, you're not going to be puking. If you're not puking, you're going to mobilize. No pillow between the legs, home sooner, quicker recovery. All really, really good things. That's just that same picture of the hip going in before, what it looks like on x-ray. Cup, you can see the screw. This metal is the new stem inside the thigh bone, which is the other shade of gray here, and the ball is inside the socket. And so that's during surgery, so you know everything's right. I wouldn't be a talk unless I told you about the bad things as well. It's not always great. There is a risk of infection. We give you antibiotics before and after surgery. There's a risk of blood clots. We put you on a blood thinner for 35 days. It's a pill. There's a chance that the implant could break, very rare. Malalignment, once again, this was more so when you were doing it from the back because you didn't know exactly where your position of your components were. Premature wear, if you start jogging on your hip, you're going to wear it out sooner. No implant will last forever. It's plastic, quite frankly. It's plastic and metal. If you rub plastic and metal together all day, every day, the plastic will wear out, and that's the weak link. Yeah?
So what happens after they wear out?
After they wear out, wrong computer, you basically, remember that plastic piece that's sandwiched in between? You basically open it up. Think of that as your brake pad. You basically open the hip up, take out the old brake pad, put a new one in, and you don't have to cut any bones or anything. So it's a much quicker recovery. The idea is once that plastic wears out, so every 5 years we would x-ray your hip to see where that plastic is in its wear pattern. And just like the brake pads on your car, if you catch it before you get to the squeaking or the metal on metal, it's very simple. If you wait till you hear that screeching and stuff, or if you wait till it gets to metal on metal, you've got a bigger problem and you probably have to replace the cup. So every 5 years you get a checkup to make sure the plastic piece has not worn out. But it's a very simple fix if at 20 years it's gone. Other factors can affect longevity. Obviously, infections, overall health. And one of the other big things is you have to be healthy enough to undergo an operation. If your heart and lungs can't take it, obviously you have a higher risk during surgery. Because every surgery is stressful to the heart and lungs. There's no way to get around that. So how do you minimize any complications? Obviously, you have to see your primary care doctor first. Even before you see me, you'll probably see your primary care doctor, and they'll determine whether or not you can have an operation or not. But then even for the surgery, once you see me, we set it up. We're going to send you back to your primary doctor to say, can the heart and lungs take the operation? If they can't take the operation, we've got to figure out something else. If they can take the operation, they'll give recommendations of things and medications and whatnot to take before. Dental work, if you've got any if you've got a tooth abscess or significant dental work that needs to be done, do that before your hip replaced or your joints get replaced because it does have a higher chance of infection. And prepare home. A gentleman came today and he said he's got everything set up. He's got his walker, cane, and crutches and whatnot, but just have it all ready to minimize the things you need to do before you get home. Once again, you can return to all low-impact activities. This is a time frame, 4 to 8 weeks for golfing and swimming. You're restricted from high-impact activities, running, jumping, and jogging. But like I said, most persons, by the time they get to this, are no longer doing them. Yeah?
What about riding horses?
Absolutely, yes. It's more weight on your butt than it is on your legs, so you're good to go. Where do you go from here? Obviously, you need to see your primary care doctor first to get her. You don't always have to, but I'm here for a limited amount of time, and so I frankly would rather see the person's after they've seen their regular doctor to see, you know, a lot of times it may not be arthritis of the hip, maybe the back, or it may be something else, and it may be something that they simply just had injected or sent you to therapy and the problem goes away. Your primary care provider will determine if you're medically sound and if seeing a surgeon is right for you at that point. I'm happy to see and things like that, but it's often better to go through your primary doctor first. So, questions? Just one quick thing. I see the patients over at the Crone Clinic. I am independent. I'm not part of the Crone Clinic, but obviously I use their services and their space, so I see people there. Surgery is done here. I do schedule not through the Crone Clinic. You'd contact our office in Wisconsin Rapids. We get everything set up through the Rapids office. Gina is one of the girls you would talk to at this extension for scheduling. She's kind of the administrative type person, and Dawn, who is the nurse, who is part of every surgery, part of every clinic visit, and all those stuff. She has a different extension, but she's the other one that we would talk to for most things. She is here, and she'll talk to you afterwards as well. So Dawn's in the back, but she's in the back, but she's there, part of everything. So questions at all? Yeah.
If you have problems with your pelvic twisting, never staying in place, how does that affect the hip?
I'm not sure. We hear a lot of times people will see the chiropractor or whatnot, and they'll say the pelvis is twisted or turned or whatnot. Quite frankly, if your pelvis is, let me get to a picture here. I don't really know what that means, to be honest, first and foremost. If I can get to a picture of a total hip here. If your pelvis is twisted, say, I don't know, twist it this way. There's enough motion in this hip to make up for it. So I'm not really sure when the chiropractor says, no offense to chiropractor, I just don't understand it. When they say it's twisted, how that's going to cause any problems here if I have oodles of motion at this hip joint. Now, if I already have limited motion at my hip joint and my pelvis twists, yeah, you'll have groin pain, but it doesn't affect the operation because there's so much movement with that ball and socket that if you're twisted 5 degrees, you've got 140 degrees of motion in that hip joint. So quite frankly, a twist of the pelvis, I've never seen it become an issue or a problem. Yeah?
If your heart and lungs aren't the greatest, what else do you need?
If you went to your doctor and they said there's no way in this green earth that will allow you to have an operation, typically you're doing those things that you saw way back in the beginning. Mainly it's activity modifications, medications, injections into the hip, meaning a steroid shot. Those are done under x-ray. Those aren't the ones that are done in the clinic. And usually a cane or a crutch or something to, yeah.
I've been through it all.
All right.
And
So
they said that there is no hip joint. And I already been back to physical therapy with Bill. And I got to go in tomorrow to talk to a sleep study doctor because I had to do sleep study. But I don't know, I don't know if he talked to you or the Dr. X that used to do it.
Yeah, I didn't talk to me, so I don't know who you're.
Because it was Kevin Anderson.
Yeah.
And
Nope.
at that time I had an abscess tooth, and he said he couldn't do it.
Yeah, with tooth abscesses and problems with the teeth, you get that cleared up before you would do the hip replacement.
Well, that's done, but like she said, I had a heart attack once. And I got COPD.
Yeah, so I mean, that's the unfortunate part. If your medical doctor won't clear you for surgery, there's no way I would put a knife to your skin.
Well, what he told me, he thought maybe it would be okay.
Well, and that's up to them. So if you see, Dr. Anderson or whoever, and they say it's okay to proceed, absolutely, you can come see me. But if they tell you there's no way they're going to let you have an operation because it would potentially kill you, then there's no way. So, yeah, it's a tough spot to be in.
But then again, the pain is so bad that even the medication don't help that much anymore.
Right. That's the hard part. Any other questions? Yeah.
Why is the blood loss the same if you're cutting through that?
There's more blood vessels. There may be less tissue or less muscle planes, but the blood supply to our hips kind of goes through the back and around the front. It's called, more than what I know, it's called the anterior circumflex, but it's the main artery to the ball. Obviously, we're cutting the ball off, so you don't need it anymore. So we actually coagulate that. But there's all kinds of little perforator or little bleeders that go along with it. So that's why there's more bleeding. The blood flow to the anterior hip or the capsule is more so than the back. Great question. Anything else?
The procedure, you said there's just the one screw goes in?
Sometimes, well, it depends. You can use 1, 2, 3. I think there's 4 spots for the cup I use. Sometimes we'll use none. If you did a metal on metal, for example, like a cartoon, no screws went in. But if you don't have to, I put it in. It adds about 10 minutes or 5 minutes to the case. I know a lot of surgeons don't put it in, the screw, because the hole you drill is smaller than the size of the cup you pound in. And so it press fits in there. I put it in there just because I'm chicken, I guess. I put it in there to hold the cup until your body grows into it. Many people.
I mean, what do you, until your body grows into it?
Well, because it can toggle or loosen.
Okay.
So the screw is just to hold it there tight. And once your body grows into it, that screw sits there fat, dumb, and happy because your body's holding the cup. It grew into the cup. So the screw really, it's inside the pelvis, so you don't feel it. You can't feel inside your bone. And so it holds that cup there so you can get up and walk on it immediately. If you wouldn't be there, you still can get up and walk on it immediately, but there's a chance if you'd have a fall, you could toggle that cup loose. And for 5 or 10 extra minutes, it's probably worth it.
What blood thinner do you use?
Great question. We used to use Coumadin or warfarin. We don't use that anymore. We use something called Xarelto, which starts with an XA. And we use that because you don't have to go to the lab and get blood draws. You still have to take it for 35 days, but you don't have to go get a stick every week. So it's basically it's approved for joint replacement, blood clot prevention, and now it's approved for heart atrial fibrillation, I think.
Do you use a staple or a stick?
Both. Staples on the skin, stitches underneath. But if somebody, we've done a couple where we use stitches on top because they couldn't tolerate the metal and whatnot. But no problem. Anything else? Yeah.
You mentioned the ceramic.
Yeah. Yeah, I do. Yep. That picture I showed that looked like the breast cancer awareness hip right there. This one is it's a pink ball, but that's ceramic. And that I put in a woman. And that was probably a couple months ago, 2-3 months ago. But yes, one of the risks with ceramic is, and it's not so much anymore. About 15 years ago, all the ceramic that was put in total hips was made in France, and they got a bad batch about 15 years ago, and so some of them cracked and broke. That hasn't been near the problem over the past 10 years. Persons that we would not put, it's more expensive, number one. So your idea of using ceramic on plastic is it will last longer. So if you're a 40-year-old male, great. If you're a 40-year-old male who skydives, bad. Because if you break this, you're going to start over, number one. Number two is it's made of sand, ceramic is sand. If you break it, it doesn't just crack. It basically shatters. So now you've got all kinds of grit inside the hip joint, which when you walk is going to cause that plastic to wear out. But yeah, I definitely do ceramic on people. Absolutely. The idea is you can get it to last longer. So if you're somebody who's not going to do the high abuse of it, and you're of young age or in a good activity level, absolutely that's the right thing. And we put it on top of, put that on the vitamin E plastic to get the longest wear characteristics of it. And the other one, the metal, so the other option is more than you want to probably know, but the other option is the metal on metal. This, where you've got a metal cup and a metal cup and a metal ball. This is designed to last a long time as well. And they have that option where you can put a metal ball on instead of having a plastic liner in here, you can put a metal liner in there as well, or just a metal cup, and that will last longer. But if you stay up late at night and you watch the news, that's the one, not Biomed's, but another company's got theirs recalled for having metal rubbing on metal. And that I would not do, no offense to you, but I would not do metal on metal in any of the females in the room because it fails more commonly in females.
Is there a recommendation age-wise? If you're 40, you recommend this versus 7-year-old, you recommend this?
A 70-year-old, this. You know, if I'm going to get 25 to 30 years out of it, fantastic if you're 70. This is tried and true. It's going to work. If at 105 we need to go in and pop the plastic out because it lasted that long, great. At 40, you do something that's more expensive because you're trying to get that longevity. The time in between is where you're having a hard time. The gentleman who I said just walked out of the clinic the other day, we did ceramic on plastic. He certainly could have done metal on metal, but he didn't want the increased cancer risk. There's another gentleman that had worked in the mill for 20-some years, and he said, listen, I don't care about cancer. I've worked in the mill around chemicals my whole life. If I get it, I got it. Just do the metal on metal. So I think at the young age, you're going to do what you think. Basically, it's a discussion between the patient and myself. What risks are they willing to take? Are you willing to take a risk of breaking the implant or the implant possibly giving you cancer? It's never been proven to give you cancer. Don't get me wrong, but that thought process is out there. So what you do for the person is really worth there when they stratify where their risk is in a discussion. I mean, I've done it both ways. Yeah. Go ahead. Knees? Well, what do you mean? Yeah, there's a total knee replacement or a partial knee replacement. I use Biomeds for those as well. They have a partial knee, which is called an Oxford, which is a very select group of people that can receive that, or a complete knee replacement, which is, I don't have any pictures of it, but there's samples in the back as well as information, and we do them all. I mean, for every 5 knees you do, you probably do 1 hip, or 10 knees you do 1 hip, just because knees wear out faster. Yeah.
Is there a less invasive knee procedure?
Yeah, there's no, knees have gone through this kind of swing where they were a standard knee approach, then we did a minimally invasive knee approach, and now that's the standard. So to say that there's a new standard for it, not really. It's the same standard that's been there for about 7 to 8 years. And what happened is when we had this large incision, the engineers once again got a hold of the tools, the incision became smaller, and now that's where we're at. So there's no different approach. There are some goofy approaches to it, but I don't do them because quite frankly, they never bore out in the literature to matter. So.
But is it less invasive, less length of recuperation?
I wasn't around when it used to be, so I'll use that as the caveat. But if we did a knee replacement on a Wednesday, you either go home on Thursday or go home on Friday. The ones we've done here, I think 50% went home the next day. The other 50% home went in 2 days. But those ones that went in 2 days, we did both their knees at the same time. So that's, not fair to compare them to the ones who had just one done. Yeah.
I had both my knees in Rochester. Had them both done
Mm-hmm.
at the same time in Rochester.
Yep.
And I was there for 1 week, and I came home, and my husband helped me with my, the therapy.
Yeah.
And stuff. I had no problem.
Good.
And that's been 15 years ago.
Yeah, that's fantastic.
But now it's the hip. So.
Yeah. Just out of curiosity, and who here, this is my own research study, who here has a Gunderson Lutheran Health Plan? Anyone? Good. Good. Gunderson Lutheran won't let me on their health plan, so I was just going to tell you to call them and gripe to them. So.
Have you ever seen, I think with her, that she would favor the good hip, and by doing that,
wear it out?
Wearing it.
Oh, absolutely.
Do you get in there and see that you got 2 bad hips, or?
Well, you're only going to look at, a lot of times, yeah, if somebody's got a bad hip and put it off, or a bad knee and put it off, we know the other side's going to bear the brunt, and you'll wear that side out quicker, absolutely. It's interesting, a lot of people will come in with knee pain, back pain, and you'll take care of that problem with the surgery, and they'll come back and see you, 6 weeks later or whatever it is. Number one, we always hope the biggest complaint you have is, I wish I would have done it sooner. and that is typically the biggest complaint. Number two is they'll say, my back pain went away, or my other side no longer hurts, or those types of things, and that's a very common complaint. But often if it's a hereditary issue as why your hip hurts, you probably got the same thing going on the other side. You've taken just as many steps in your life with your right leg as you have with your left leg. So if one's going to bad, the other one's probably got some degree of wear or some degree of problem as well.
I have a hip that was done 14 years ago. Now the other one is going. What's going to happen to this one now if I'm going to wear?
I mean, if it's already done, you're just wearing out the plastic no matter what you do. So really nothing. It's really not even a thought process.
It's not ever giving me any trouble.
Yeah, and so if it doesn't give you trouble, you don't fix it. But every 5 years, you should at least have it x-rayed to make sure the plastic isn't wearing out. Because if it was 15 years ago, it's a plastic piece in the middle. And at least the surgeon who put it in or somebody else should at least take a look at it. All right, anything else?
With this new procedure, have you had to deal with any of those complications that you had listed?
I absolutely. The surgeon who tells you they haven't had a complication is a liar. So let's go through that list. All right. No, and the reason being, I think, and this isn't, there's no literature to support it because the anterior hip has not been out. If you jinx me, by the way, I'm going to find you. We got names, right, of the people that signed up? All right. So why I don't think it's an issue is there's more blood flow. How do we fight infections? We send blood at it. Blood has the cells that kill the bad things. So I think that's why I haven't seen that. And number one, I'd like to say it was because of me, but I think it's probably Mother Nature. Blood clots have not. Even with the new medicines, Xarelto versus Coumadin, have not. Why? Because we get up and move you right away. And the number one thing that's going to cause a blood clot, in the old hip system, the number one thing that caused the blood clot was dislocating your hip. That's where all the blood clots formed. We don't dislocate your hip, we cut it off and then pull it out. So you don't have the torque on the blood vessels. So that's why I don't think we see this. Implant breakage, that's a historical thing. Malalignment, I can think of one for sure I wasn't happy with, but it was in, so is it a complication if I change it? I don't know. I was in the surgery, put the parts in, looked at it, didn't like it. Just took all the parts out, put them back in again. And she's no worse for wear. It was all one surgery. She never, I told her I did it because the surgery took a little longer, but I don't consider that a complication because we were inside. Premature wear, I haven't seen it yet. I've only been here 6 years. It won't last forever. Cardiovascular compromise, absolutely. Whether a person heart can't take it or lungs can't take it, those types of things. But the true mechanical structural things that I at least have somewhat control over, no. One of the knocks on the anterior hip, we mentioned blood loss, but if you've had a knee done, your knee replaced, you always have a numb spot on the outside part of your knees. To get in for an incision here, often you'll have a little numb spot on the outside of your hip. Usually starts out about like that, gets down to about something like that. So that's one knock on it. If you say, well, why, what's the bad part? And usually it's that numb spot stays there. It just feels goofy when your pants rub across it. So, and I have not seen a dislocation. Knock on wood. Had the complication, if you're not trying to scare anybody, the complication I just dealt with yesterday is woman this is not her. She broke her bone right here. A couple weeks after the surgery. So fracture is a risk. No offense to anybody, but actually, looks like everybody's white here. We all get osteoporosis. Females get it more so. So white females are going to get osteoporosis. She's got weak bone. 2 weeks later, she broke. So did I cause it? Maybe by putting the metal in her thigh bone. Did it break because white females get hip fractures at 80 years old? I don't know. I would think that if I caused it, it would have happened the first week and a half she was walking, but I can't prove that. So she had a fracture here.
What did you do for that?
Wired it together. Surgery and just wrapped wires around it. And we put a new stem in too once we were there. But
So if somebody does have thinning of the bones, there is hope for them.
oh, absolutely, absolutely. All bets aren't off. No, absolutely not. I've never not done the surgery because I thought somebody's bones were too weak. You're up walking. I mean, if you're not walking, then they'll get that weak. But, if you're able to walk and get around, I'm not worried about that. But that's the first time I ever saw that. So live long enough, you'll see everything or do everything at least once. So, what's that? She did not. She was getting off a chair or a toilet, I believe. I don't know which one, but she was walking around doing everything the day before, or that morning even. So, but sometimes no matter how you try to explain it, you can't. And even in surgery, I couldn't explain it after looking at it.
How long does the surgery usually take?
Surgery takes about anywhere from an hour and 15 minutes to 2 hours. Depends on what you run into, or the bleeding level, or how hard the bone is.
What do you do with the plates in there?
That thing that grinds them out, that piece?
Well,
the coring reamer?
Like in my x-ray, it showed like little speckles, he said, of the bone.
Oh, you just take them out and throw them away.
Oh, okay.
You don't need them anymore. Yeah, you get rid of it. So, yeah, don't feed them to the dog. True story. I gave a person their parts once. Their dog ate them. So just imagine laying there at night and your dog just ate your bone, thinking that actually tasted pretty good. So as you fall asleep, just think of that. So no, I can't give you the bone. Actually, the Center for Disease Control out of Atlanta, Georgia, says I can't do that. So I got in trouble for that. So I won't give you the bone back. Any other questions? Otherwise, the implants and stuff are in the back. Dawn is in the black, not the one standing. Dawn is in the black with the blonde hair. She can answer any questions you have. Nick is on the other side, but feel free to play with the implants, ask questions, things like that. And like I said, if you have any questions or concerns, the number on the card, our cards are back there. There's a number for Dawn and a number for Gina. Gina does the scheduling if you ever get to that point, okay? And you can always call and just ask questions. But thank you for your time.